Hello, thank you for joining us. My name's Sophie Nelson. I'm a GP with special interest in gastroenterology, working at Manchester Royal Infirmary, and I'm joined today by Dr. Mike Burkitt, one of the consultants here.
Hello, I'm Mike Burkitt. I'm the clinical lead for gastroenterology and hepatology at MRI and Trafford General, and we're going to talk about a few different scenarios where we see people with upper GI symptoms.
So the first case we were going to discuss is that of a young man, aged 40, who presents to the GP with simple heartburn symptoms. He has an H.Pylori test, which comes back as negative. His GP then starts him on 20 milligrams of omeprazole twice a day, which solves his symptoms, but as soon as he stops taking this, they recur. So I just wanted to discuss how to proceed at this stage, because I think a lot of GPs would wonder about whether that patient warrants an endoscopy.
So I think it's really valuable at this point to bring in the dyspepsia guidelines that we've developed with the CCGs and Greater Manchester endoscopy over the last year or so. And they helpfully guide people in primary care towards the right decision making in this situation. So a patient who's young, without other risk factors, who has had a good response to a PPI in the first instance, really doesn't need to go straight for an endoscopy at that stage. We know that the diagnostic pickup rate in that situation is going to be very low, and we're unlikely to find serious pathology. So we would very strongly advocate that we carry on treating with a dose of PPI that's effective, and that might need to be titrated down to a minimum effective dose, but it can be continued for a number of years. If people are on PPIs for a good few years, maybe 5 years, and still have symptoms, if they come off the medication, it's probably worthwhile considering an endoscopy at that stage, but certainly in the acute phase they don't need an endoscopy.
Lovely. And you mentioned risk factors, the absence of risk factors. Who should we be a bit more careful about?
So if you've got a person who's in an older age group, over 55, who've also got weight loss, and particularly if they've got abdominal pain, reflux and dyspepsia symptoms, those people all make it into the HSC 205 criteria for a 2-week wait gastroscopy, as do people presenting with true dysphagia.
Okay, so why might you want to do an endoscopy in someone with longer term symptoms?
So realistically, the reason for doing an endoscopy in someone who's got long-term dyspeptic symptoms, particularly if they've got symptoms that you might think are related to acid reflux, is to think about their risk for pre-neoplastic, so precancerous conditions in the upper GI tract. By far the commonest of these in the UK is Barrett's Oesophagus. Which we know increases an individual's risk of esophageal adenocarcinoma, which is one of the few cancers in the Northern Hemisphere which is increasing in prevalence and increasing in mortality. We know there are some risk factors for that. So we know that white men are more likely to develop Barrett's, and we know that people who are overweight are more likely to develop Barrett's, mainly because of their risk of having long-term acid reflux.
So what would you suggest if the patient that you give the 20 milligrams of omeprazole to twice a day either doesn't respond or responds partially?
Well, if the patient really doesn't respond at all to that dose of a PPI, I think it's reasonable to say that they're unresponsive to PPIs. And at that stage, it's probably reasonable to arrange a community endoscopy just to see if there's something different that's causing the problem that might need a different approach. On the other hand, if they have responded and their symptoms have got a bit better, but there's still some residual symptomatology, it's very reasonable at that stage to think about other things. You can increase the dose of PPI probably up to something equivalent to omeprazole 40 milligrams twice daily for a maximum of about 8 weeks, and then look at reducing that dose again. Or You could also look at adding in other treatments like alginates in the form of Gaviscon, which are really helpful in some patients with reflux. If after you've given them a high dose of PPI, omeprazole 40 milligrams twice daily for 8 weeks, they still haven't responded, or they haven't fully responded, and you're not able to reduce that dose, I think that's a reasonable indication for going for an endoscopy at that stage as well.
Thinking about one of the sections in the dyspepsia pathway, it recommends that we check someone's Helicobacter pylori. How important is it to check this? And does it matter if we test and treat or if we treat and test?
So I think that testing for Helicobacter pylori is really important. It's an independent risk factor for developing these symptoms, but it also can be associated with more serious GI disease as well. And if we don't test for it, we obviously won't make that diagnosis. For me, the most important thing is to have a logical pathway in how you test people, and certainly some of the medications can impede testing for H. pylori to some extent. So I would definitely recommend that you test your patient as soon as you have an opportunity, and preferably before they start taking any acid-suppressing medications. We know that the prevalence of Helicobacter pylori in the northwest is about 1 in 5, 20%, and that's based on a big study done in the northwest of England about 5 or 6 years ago. So it's pretty recent data, and we know that it's well worth looking for these patients because we can actually eradicate that risk factor for them.
Okay. So we know that we need to, if someone is on acid suppression medication, that we need to stop that 2 weeks before doing the test. Can you cover with anything else during that time for people who get quite bad recurrent symptoms?
So that is certainly a difficult situation, and we have a lot of people who struggle when we ask them to stop their PPIs. Clinically there are very few indications where stopping PPI is actually contraindicated clinically. The people who you can't stop the PPIs in would be people who've got a recent, as in within the last few weeks, ulcer, or people who have a definite diagnosis of a gastronoma, and they're very few and far between. In terms of people who develop symptoms when they stop their medication, we can cover with simple antacids and with Gaviscon, which might help for some people, but unfortunately anything that suppresses the acid production is likely to reduce the validity of a test. In the end, though, doing a test is better than nothing, so if your patient really can't stop their medication, I'd rather we did the test and missed a few cases of H. pylori rather than just not testing.
Lovely, thank you. So could you just summarise for us the link between Helicobacter pylori and gastric cancer?
So I think it's worth thinking about H. pylori and what it does in the stomach. Essentially, anyone who's colonised with H. pylori will by definition have a gastritis, an inflammatory process happening in the stomach. And most people who have H. pylori, that's a benign process that just sits there, and they either get symptoms or they get nothing and don't know it's there. For a very small population, there is a progression down a pathway that leads to cancer, which develops over about 30 to 40 years in most people. So it's not a rapid change, but it is something that happens in about certainly less than 1% of people affected with Helicobacter. But that having been said, H. pylori colonisation is associated with about 80% of cases of gastric cancer worldwide. So it is a really important risk factor, and it's well worth thinking about, particularly when you have people with more serious presentations. So gastric cancer is relatively lower incidence than it used to be in the UK. There are now about 7,000 cases, and we've seen that reduce over about the last 20 years continuously, probably as the incidence of H. pylori has dropped because we've been detecting it and eradicating it. It's also worth remembering that H. pylori associated gastric cancer is definitely a disease of relatively old age, and most patients who present with gastric cancer will be in their 7th or 8th decade of life.
Okay, so if we have a patient who's found to be positive for Helicobacter pylori and we treat them with the first line antibiotics and PPI, and they have persistent or recurrent symptoms, when would you consider retesting?
So I think it's really important to say that in primary care, if you find someone's got H. pylori, you give them eradication therapy and they get better. We don't need to confirm that we've eradicated the bug. We'll assume that that's happened. If, on the other hand, you've treated them and you've waited 8 weeks, you've given them symptomatic medication over the course of those 8 weeks, and you still have someone who has troubling symptoms, then I think it's well worth checking to see if your eradication has been successful. We do know, and the World Health Organization has identified this as a major problem globally, that H. pylori is becoming increasingly resistant to the common antibiotics that are used. There are guidelines for the first and second line treatments for H. pylori, and if your patient has persisting H. pylori after the first line therapy, you should go ahead with a second line attempt to eradicate it. One of my particular interests is Helicobacter, and I think it's really important to recognise that what doesn't happen in adulthood very often is that a patient reacquires H. pylori. So if your patient has sequential positive tests for H. pylori, it's highly unlikely that they are reacquiring it in the community. That's because we catch H. pylori almost exclusively through vertical transmission when we're in young childhood, when our stomach microbiota and our stomach environment is specially adapted in a way that H. pylori can utilize. So if your patient has a consistently positive test, it suggests that they have a resistant organism or that the treatment is not working for some reason, and that's a good indication to refer them on to secondary care.
So if we go back to talking about our patient who is this 40-year-old chap with heartburn, and if we assume that there was no response to the PPI that we started him on initially, and he ends up having an endoscopy, if we get the report back that shows that he's found to have gastritis or esophagitis or general inflammation somewhere in his GI tract, how should we manage these findings in primary care?
So I think it's really important that you realise that certainly esophagitis is a reflection of someone having gastroesophageal reflux disease. So it's all part of the same continuum that we'd expect to find these problems, and a lot of them are driven by acid, particularly if we've already excluded H. pylori as a cause. So we would always advocate a good dose of proton pump inhibitor. In this sort of situation, I usually recommend that someone has omeprazole 40 milligrams or equivalent twice daily for 8 weeks, and then that dose is weaned down. So most people will have a major improvement in their symptoms with that treatment, but it's really important that at the end of the 8-week course we look to find either the lowest effective dose to maintain their symptoms or try to get them off the medication altogether. But it's important that we do that gradually, because there is a risk of rebound acid secretion as you stop a PPI. As you give someone a PPI, they get a high level of gastrin in their system as a response to that drug, and that drives the increase in parietal cell growth in the stomach. And by doing that, it means that as you come off the drug, there's a lot of cell mass there that can produce acid rapidly, and we need to just manage that time, which normally only takes a few weeks to change, and the best way of doing that is to gradually wean them off their PPI and cover them with other things that don't suppress acid, such as Gaviscon, to try to get them through that period where they may get symptoms.
Are there any other lifestyle measures that we could suggest to these people to help improve their symptoms?
Well, there certainly are a host of things that are on paper extremely simple and may help. They include raising the head of the bed, eating small meals, not eating too late, making sure that you avoid alcohol, not smoking, losing weight. All of these things are really simple things to advise. They're not so simple for patients to initiate, and I think it's really important that we recognise that. One of my favourite pieces of advice to pass on is that if we can have a patient lose 2 kilos of their body weight, they'll often see a reduction in their acid reflux symptoms, even if it doesn't bring them down to a normal weight.
So if the same man was to have gone for his endoscopy and found that actually this was normal, the pathway suggests that we consider the diagnosis of functional dyspepsia. Can you talk to us about exactly what this is and what the options are for his management at this stage?
So functional dyspepsia is an umbrella term really for people who are getting symptoms from the upper GI tract who don't have demonstrable organic pathology when we do an endoscopy essentially. And it probably includes a group of different people. Some of them have true gastroesophageal reflux disease but no mucosal pathology related to it. Others of them will have something that's probably better described as non-ulcer dyspepsia, which is really just a term that means the stomach looks normal but they feel unwell. And this is really an upper GI version of the common presentation with irritable bowel syndrome. And I think it's really important to recognise that when you've had a normal upper GI endoscopy in someone who's got clear dyspeptic symptoms, clear symptoms that are coming from the upper GI tract, but their scope is normal, we're probably thinking about how we manage those symptoms rather than looking hard for new pathology that we've missed.
Would you consider maximising their PPI at this stage to see whether that helped with their symptoms, or is there no point in doing that?
So it does depend what's happened in the previous steps of the pathway, really. So if there's someone who's responded a bit to a modest dose of a PPI and you've never tried a high dose, I think it's perfectly reasonable at that stage that you try high dose PPI and see what happens. And I'd be thinking 40 milligrams of omeprazole twice daily again. If that helps, then great, there's a good reason to carry on with it. But we're really thinking about their symptoms. If that doesn't do anything, then we should wean them down off the PPI and either stop at the minimum dose that actually helps them or take it away completely if it's really not contributing to the treatment at all.
Okay. Do these patients need referral into secondary care, or is it something that we can reasonably manage out in the community when we've got the results of their endoscopy?
So once you've excluded serious pathology with an endoscopy, I think this really is something that can be managed in primary care, but also probably more importantly, it's something that we need to start engaging with the patient about self-care, because this is a symptom that they're likely to have long term and for which there may be some medical interventions that help a little bit, like a PPI or some Gaviscon may help, but it's also quite likely that they're going to need to think about lifestyle modifications and working out how they live with these symptoms and manage them themselves. And there are some really good resources for that. The Manchester CCGs have produced a very nice functional dyspepsia leaflet that gives good guidance around that. And similarly, Guts UK is a charity that's got a very good website and patient information leaflet about dyspeptic symptoms, which I think can be really helpful for patients.
Is there anybody that you think we should refer into secondary care earlier?
So there are a few groups of patients who present with upper GI conditions that probably do need a little bit more prompt management. One of the big groups is probably people who've got diabetes who present with vomiting, because of course diabetic gastroparesis is quite a common problem, and it certainly deserves early assessment because there are things that we can do to improve patients' quality of life with that condition. The other group who have some quite tricky symptom control issues and often will have complex functional problems are people who've got connective tissue disorders, particularly scleroderma, though other connective tissue disorders can also have problems. And they're worth referring early so that we can assess them fully in secondary care. And I suppose the other group, just to bear in mind, and I think no podcast about upper GI symptoms can go away without mentioning this, is that people can have family history risks as well. And there are familial forms of gastric cancer. So if people have got a family history of gastric cancer early in their parental generation, so people who diagnosed before the age of about 40 in the family, they definitely deserve an early referral so that they can be sorted out both from a gastroenterology perspective and also possibly referred on to clinical genetics as well.
When does surgery for acid reflux become an option?
So I think it's really important to realise that only about 1% of people who are investigated for acid reflux end up having an operation. The vast majority of people don't have operations. And there's a number of reasons for that. One is, I guess, a health economics thing, that we can't send everybody who's got reflux for an operation. But the other very important factor is that actually having an operation is not a simple fix. A lot of people who've had operations will then have post-procedural issues. They may struggle with a normal diet. They may get symptoms like gas bloat where they're unable to belch, which can be extremely uncomfortable. And surgery is not always a long-term solution. So people might have 10 years of good acid control, but it may not be longer than that. And if you're talking to a 25-year-old with gastric acid reflux, really 10 years is not anywhere near enough time to advocate a major procedure for. But that having been said, the people we do find ourselves referring on are people who either have inadequate control with regular acid control medication, or who are really struggling with that medication, either because of side effects. So we do have a few people who get magnesium wasting when they're on PPIs in particular, and those are people who we may have to think about surgery earlier, or people who just don't like the tablet burden and are not good at continuing with that medication. And those are all good enough reasons for referral to a surgeon.
And as GPs, would we refer directly to the surgeons, or would they come via gastroenterology?
So for me, as a gastroenterologist, I think this is a group of patients who definitely benefit from meeting a gastroenterologist. Partly that's about allowing us to really make sure we've optimised the medical management, because if that's going to be adequate, that may be their best option. But also it's a little bit about ensuring that we structure their assessments properly and allowing us to build an MDT approach towards these decisions. So in MFT, we're currently establishing an upper GI benign MDT to allow us to discuss the physiological tests that all patients who go forward for surgery need to have in a group where we try to direct them towards the best option for them, whether that's surgical or medical management. And we're hopeful that over the next few months we'll see a big improvement in that service, and it'll be something that we can support GPs with well. I suppose the final thing to say about functional GI surgery at the moment is that we are really restricted in what surgery can be provided as we come out of the COVID pandemic. And I don't see a route back to normal practice for several months yet. And these patients are definitely not being prioritised at the moment because they're having treatment for symptoms rather than for life-threatening conditions.
While we're talking about COVID, I think it's worth mentioning that the waiting times for gastroenterology were always quite long. And now, since the pandemic, they're significantly longer, both for outpatients and for endoscopy. Are there any ways around that, and what are the best ways to get advice if we are concerned, but it's not something that needs urgent discussion on the day?
So you're absolutely right that we do have long waiting lists at the moment, and we're under immense pressure because of COVID. That having been said, we have been able to modernise quite a bit of things that we deliver during the pandemic, and one of the real benefits is that we've been able to bring in an advice and guidance service through the ERS. I'd really advocate GPs using that. You're likely to get a response reasonably quickly, although I'll be honest that whilst we've been contributing to COVID care in the hospital, that's been difficult to do. Hopefully, as we come out of the second wave, I hope, we will see an improvement in our ability to address advice and guidance queries quickly. And I think that's an ongoing way of helping out our primary care colleagues, and I hope a lot of the patients who we need to contact or be involved with can be addressed with that sort of treatment.